continue our discussion back to the blood. All right, so remember, we've got 4 blood types according to the ABO blood typing. We've got blood type AB, we've got blood type B, blood type A, and blood type O. So for blood type AB, I have both antigen A and B on the surface of the cells. Blood type B, I have antigen B on the surface of my cells. For blood type A, I have antigen A on the surface of my cells. And for blood type O, I didn't have neither A or B on the surface of my cells. Remember, if I don't have the antigen on the surface of my cells, this is gonna be a non-self antigen, and my immune system will start to consider it as a foreign antigen, and I will start to attack it, forming antibody against this antigen. All right. Remember, how did we test the blood type? We did mix the blood with anti-A, anti-B. And if I did have the agglutination reaction with anti-A, this means that the blood I'm testing has antigen A on the surface of its cells. If I did have agglutination reaction with anti-B, this means I have antigen B presented on the surface of my cells. That's why I've had this agglutination reaction. So if I have agglutination with both anti-A and anti-B, this tells me that I'm dealing with a blood group type AB. If I'm dealing with a blood group type A, I will see only an agglutination reaction with anti-A. And if I have only an agglutination reaction with anti-B, this tells me that I only have presented on the surface of my red blood cells antigen B. So I am a blood type B. If I am a blood type O, I won't see any agglutination, neither with anti-A or anti-B. Remember, we did also discuss a little about the RH blood typing. And remember, we do have 2 types considering the RH blood typing. If I'm dealing with RH positive blood, this means that the red blood cells are presenting antigen D on their surface. And if I'm dealing with RH negative, this means that the red blood cells are not presenting the D antigen on their outer surface. Remember, don't give the antigen to a person who is not presenting this antigen on his cells, because if I did give antigen D to a person who is a blood group or who is an RH negative, what will I have? I will have a formation of anti-D antibody. All right, so again, if I am RH positive, I'm presenting antigen D on the surface of my cells. I can't give blood type who is a blood type RH positive to a person who is RH negative, because simply an RH negative person will consider the D antigen as a non-self antigen, and so he will start to produce anti-Ds that will be targeting those transfused cells. Remember, we did have a discussion of what is the clinical application here of the RH blood typing. If a person who is RH positive got married to an RH negative woman and they have a baby who is RH positive, remember, the first baby won't have any problem because there is no direct exposure between the immune system of the mother and the baby. No direct exposure. So this means that the mother's immune system will not be producing anti-D that will be attacking the red blood cells of the baby. But what happens during labor, some of the red blood cells of this baby gonna be passing to the mother's circulation. And those red blood cells carry the D antigen, so or Rh positive. And now the mother got exposed for the first time to the D antigen, so she will start producing anti-D. The problem with anti-D is it's a form of immunoglobulins that is very small and it can travel through the placenta. And remember, who will have a problem here is the second baby. Second baby, if was Rh positive, what's going to happen? Anti-D antibodies would be traveling from the mother to the baby, and this will cause the destruction of the red blood cells of the fetus. Remember, this is what we've called erythroblastosis fetalis. So just to give you an imagination about how the erythroblastosis fetalis looks like, most likely the baby will be born dead, or it's going to be or in other words, it's going to be a stillbirth. So this is how the baby gonna look like. You see here major jaundice because of the major destruction of the red blood cells. If you remember, when you break down the red blood cells, the hemoglobin would be released. Hemoglobin, the heme part, gonna be broken down into the ions that you're gonna be recycling, and the bilirubin that will be conjugated in the liver to be released in the bile. So if I have major destruction of the red blood cells, what's going to happen? The destroyed red blood cells will be releasing lots of bilirubin, which will cause this major jaundice. And because of the major inflammatory responses that I will get, also this baby will have this major edema and major swelling of all the tissues. What happens in a mismatched blood transfusion? If I did have a mismatched blood transfusion, remember, you're giving a person red blood cells that carry an antigen, whatever antigen, let's say antigen A on the surface of the transfused red blood cells, to a person who doesn't have antigen A on the surface of his red blood cells. So the recipient is going to be producing anti-A, immunoglobulins, antibodies against antigen A. So when those cells get transfused, simply the immunoglobulins will start to attach, agglutinate the transfused red blood cells together. And remember, your capillaries will only allow one red blood cell to pass at a time. So if I am agglutinating many red blood cells, I'm attaching them together and I'm trying to squeeze them through a very small diameter of the capillaries, those red blood cells are going to get destroyed. First, I would have diminished oxygen carrying capacity because I lost the action of those transfused cells. So you don't have those cells anymore, so they are not transporting the oxygen for you. And this is the first reason why you've transfused this blood in the first place. Another thing that those red blood cells, when they get destroyed, they will be releasing the hemoglobin out in the bloodstream. And remember, The hemoglobin is not supposed to circulate freely in the bloodstream. It needs to be broken down immediately in the liver and in the spleen, in the sinusoids, for you to recycle the iron and form the bilirubin. But here in this case, because of the major destruction of those red blood cells, the hemoglobin gonna be released out in the bloodstream, and this hemoglobin will be filtered out in the kidney tubules. And once filtered in the kidney tubules, this will cause the blockage of the kidney tubules, resulting in a major renal renal problem. Might end up with a renal failure. Here is an extra credit work that if you were capable to complete before the end of the semester, this is one of the things I would be collecting again as one file that you're going to be putting everything together, all the in-class activities that we've completed in class, all the activities that we're going to be completing in those virtual meetings, along with any extra credit assignment like this, all going to be collected together and will be submitted in the course activities, as I will show you towards the end of our meeting today. Where exactly you can find it is going to be one file. You put everything in it and you're going to be submitting towards the end of the semester. All right, so this extra credit work going to be a blood donation. Again, if you couldn't give blood for any medical or religious reason, please just get a proof that you did try to donate blood and they didn't accept because you are anemic, you did travel out of the States in the last few months or something. All right, so if you've got any reason why you can't donate blood, just get a proof of it and submit it for you to get those extra credit points that will be towards your in-class activities and pub quizzes. Moving on to erythrocyte disorders, and those are the problems associated with the red blood cells. First and most common type of problems that we're going to have is going to be the anemias. An means without, emia blood. So what I mean by not having blood means I have low oxygen carrying capacity. The red blood cells are mainly to carry the oxygen to the tissues. So if I have diminished the oxygen carrying capacity, this means I have a problem with the red blood cells and no enough oxygen gets delivered to my tissues. Anemia is a sign rather than a disease in itself. So many problems can cause anemias. So it's a more of a manifestation of the disease rather than a disease on its own. The problem here is that the oxygen delivered is not sufficient to support the normal metabolic activities. It's going to be accompanied by fatigue, paleness, shortness of breath. So why fatigue? I don't have enough oxygen delivered to my tissues, so my tissues are not capable to get enough energy, and if they are not able to produce enough ATP, they will slow down and I will feel tired. Pallor because of the reduction of either the red blood cells or the hemoglobin inside those red blood cells, so the skin color will be less red than normal. Shortness of breath, I'm not able to deliver the oxygen because of low red blood cell count. So what I will be trying to do, I will be trying to breathe faster and deeper, which will give me shortness of breath. I'm trying to capture all the oxygen available, thinking that this will resolve the problem if I have diminished oxygen carrying capacity of the red blood cells. So what might cause anemia? First set of of causes here would be insufficient red blood cells. So the way I think about anemia is like having a pizza store. And the oxygen is going to be like your pizza that you're trying to deliver to your customers. The red blood cells are like the cars that you're going to have to deliver your pizza. And the hemoglobin is going to be the driver who is driving the car for this pizza to get delivered to the customer. So the first set of problems will be associated to not having good cars. I don't have erythrocytes. I don't have enough red blood cells. Why I might not have enough red blood cells to carry the oxygen to my tissues if I did have hemorrhagic anemia? So I did bleed large amounts of blood, and this amount of blood lost from the circulation will reduce the number of red blood cells present to deliver the oxygen. It might be in acute form, so if a person had a major bleeding, I will major bleeding like rupture of a vessel, for example, in a car accident, or it might be also in chronic bleeding, like, for example, having heavy menses. This will also can cause hemorrhagic anemia. It might be due to destruction of those cars. So those cars are gonna be broken down because they have a problem in their tires, for example. So the same concept on here, if I am forming abnormal red blood cells, for example, I have spherocytes rather than those biconcave discs. So spherocytes are not going to be able to tolerate the amount of stress applied as I pass through the capillaries. So they are going to be ruptured easily. So here I have high rate of breakdown of the red blood cells. Is this what we're going to be considering hemolytic anemia? Or another definition here of hemolytic anemias would be premature rupture of the red blood cells. So the red blood cells, rather than staying, if you remember, for 100 to 120 days in my bloodstream delivering the oxygen, they have an abnormal shape, and thus I have premature rupture. So rather than remaining for 100 or 120 days, they will remain only for 40, 60 days in my bloodstream. So this will reduce the number of red blood cells available to deliver the oxygen. Another problem that might cause insufficient erythrocytes would be aplastic anemia. A means without, no, and plasto means genesis or creation. So what's a plastic surgery? What's another term that we use for plastic surgery? We use reconstructive surgery. So plasto is the construction. So here I have a problem with the construction of the red blood cells. I have a problem in my red bone marrow. This red bone marrow might have been destroyed by leukemic cells rapidly proliferating, causing the destruction of my red bone marrow. This will result in low number of the stem cells responsible to create all the blood forming elements. And remember, those are my hemocytoblast. So a person has leukemia. Those leukemic cells will start to deteriorate the red bone marrow, destroying the hemocytoblast. So I don't have stem cells to produce red blood cells anymore. So here I have a problem in the construction of the red blood cells. We call this as an aplastic anemia. So again, three major reasons for insufficient erythrocytic count, low red blood cell count. First one is going to be hemorrhagic anemia due to blood loss, bleeding. Hemolytic anemia, premature destruction of the red blood cells, most likely going to be due to a defect in the cell membrane. Aplastic anemia, I don't have construction of the red blood cells due to a problem in my bone marrow. Another set of causes here for anemia would be low hemoglobin content. If you remember, the hemoglobin did have iron surrounded by a porphyrin ring. And remember, the porphyrin ring, this is what will become the bilirubin. This is the pigment part of the heme. And remember, each one of the heme groups will be attached to a globin chain. So if I have a problem with any component of the three, this will not allow me to form enough hemoglobin to be present in my red blood cells. So if I have low iron, I don't have iron, so what will I develop? I will start to develop the iron deficiency anemia. Secondary, it might be resulting from a chronic hemorrhage. So a person who has a gastric ulcer, for example, and he keeps bleeding blood, he keeps bleeding, he keeps losing blood on a chronic basis, this will reduce the number of recycled iron particles. Remember, you recycle most of the iron except for the iron present in the lost red blood cells. Inadequate intake of iron-containing food and impaired iron absorption. All those gonna be reasons for the development of iron deficiency anemia. And remember, who is more prone to develop iron deficiency anemia, males or females? Females because of the menses, because of extra demand for iron during pregnancy. Also, another problem that might cause low hemoglobin content would be in case of pernicious anemia. And in pernicious anemia, my problem here is in the presence of vitamin B12. Vitamin B12 deficiency is gonna be causing a major problem in the DNA formation and the RNA formation. So if you remember, if I have a stem cell like this stem cell gonna keep dividing until it becomes a red blood cell, an erythrocyte. So in order for me to divide the red blood cells, I need first to duplicate my DNA. I need to replicate the genetic material. And in order to build up the hemoglobin, remember, you did need to form ribosomes, and the ribosomes are going to be built by ribosomal RNA. I need ribosomal RNA. I need, vitamin B12 to produce the ribosomal RNA. I need vitamin B12 to produce the DNA that will help me with the cell division. And I would be in need to produce a messenger RNA that will bind to my ribosomes for me to start building the hemoglobin. So messenger RNA requires B12. DNA that I'm building to replicate the cells will need B12. The ribosomes I'm building using ribosomal RNA will need B12. So not having enough B12 This results in low hemoglobin content within my red blood cells. Deficiency of vitamin B12 is not essentially due to pernicious anemia. Pernicious anemia is a subtype of vitamin B12 deficiency, in which I have a problem in the intrinsic factor released from the stomach cells that will allow me to absorb the vitamin B12. So if we're talking about pernicious anemia is a type of vitamin B12 deficiency, and this is going to be due to the problem in the release of the intrinsic factor. And remember here, in order to absorb vitamin B12 in the small intestines, I need to have intrinsic factor. So this specific scenario only is what we call the pernicious anemia. So how we're gonna be dealing with or managing a patient with pernicious anemia? Think of intramuscular injection of vitamin B12 or nasal spray. Why? Because if you simply give him tablets of vitamin B12, you go to the pharmacy, you take pills, B12 pills, those won't help, because simply the problem here is not in the presence of vitamin B12, it's in the presence of the intrinsic factor, which is essential for the absorption of vitamin B12. So my problem here is not in the presence of B12, my problem is my ability to absorb vitamin B12 has been diminished due to the lack of intrinsic factor. Other causes of anemia that we're looking at will be you did hire a lazy driver, so the driver is not working as he is supposed to. So problem here in the hemoglobin. So you still won't be able to deliver the oxygen. Like what? Abnormal hemoglobin, like in case of thalassemias, I have absent or faulty globin chains. So the red blood cells will be thin, delicate, and deficient in hemoglobin. Also, sickle cell anemia is a defective hemoglobin that results in sickling of the red blood cells in case of low oxygen. So if a person who has sickle cell anemia get exposed to a low oxygen situation, for example, he exercises. So I went for a run. So what's going to happen? I have less oxygen in my bloodstream because of the increased demand of my tissues. So this results in a deformed red blood cells. So deformity of the red blood cells takes place due to lack of oxygen. Other problems that we're looking at today for affecting the red blood cells is going to be polycythemia. So poly means many, cyte, cells, and emia, blood. So many blood cells. So all the blood cells going to be affected, all the blood formed elements, red blood cells, white blood cells, platelets, all going to be increased in this condition. But the most prominent of them is going to be the red blood cells. The red blood cells will be increased to the extent where it's going to be disturbing the blood viscosity. Remember, I don't want to have low red blood cells, because as I reduce the number of red blood cells in my bloodstream, this will reduce my ability to deliver the oxygen to my tissues. I would have low oxygen carrying capacity. I don't want to also to have high red blood cell count. Very high red blood cells would increase the viscosity. It's like pumping jello instead of pumping water. All right, so try to imagine it's going to be putting a lot of pressure on the heart. This is one thing. It puts the person at a greater risk to for developing blood clots within the blood vessels due to the stagnation of the bloodstream. The blood is going to be slowing down as it travels through the vessels. Polycythemia vera is a blood is a type of blood cancers where the bone marrow is going to be rapidly proliferating, producing all kinds of blood cells. Secondary polycythemia will be due to less oxygen available. For example, if a person did travel to a high altitude, or if I'm wearing those masks that would be reducing the oxygen pressure in the breathed air, all this is going to be causing a drop in the oxygen delivered to my tissues. And remember, kidney here responds by releasing erythropoietin that will stimulate the hemocytoblasts in my red bone marrow to proliferate rapidly and to increase the red blood cell count. So here it's a secondary polycythemia due to low oxygen levels. Also, some people will be taking injections of packed red blood cells. We call this as blood doping, and this is for them to boost their athletic performance. Any questions concerning the red blood cells disorders here? Any questions? Please feel free to write down any question on here if you do have any. So for Michel, so polycythemia, I have many blood cells. This is a broad term. Polycythemia vera is a bone marrow tumor in which I have rapid proliferation of all blood cells. So all blood cells are going to be produced at a greater number, and this will have a problem with my circulation, because if you remember, the blood volume fifty-five percent of my blood volume was plasma, and 45% of my blood volume was the red blood cells. So if I have greater number of red blood cells, this will increase the viscosity. It's going to be thicker. So the blood is going to be thicker, and as it becomes thicker, it's going to be causing stagnation of the blood. The blood is going to be, rather than traveling this fast, it's going to be slowing down, traveling through my vessels. And as it slows down, it puts me at a greater risk of developing blood clots. All right, is this better now? Is a problem with polycythemia? All right, so Hanan, if sickle cell anemia, will it go back to normal once damaged? So at normal oxygen levels, if I have normal oxygen exposure, so the red blood cells will have a normal shape. They will be sickled due to an abnormal shape and abnormal structure of the hemoglobin. You see on here, the gene mutation is going to be due to causing a substitution of the amino acid here in the position number 6 in the globin chain. You see, rather than glutamate, is going to be substituted by valine, and this will cause the deformity of the hemoglobin. So the red blood cells should look normal, but once I have low oxygen, so I have less oxygen getting attached to the hemoglobin molecules, this will cause the deformity of the hemoglobin shape. This causes the whole cell to sickle. So rather than having this biconcave disc appearance, the cells will become sickled like this and will start to cluster and block tiny blood vessels, and this will cause autosplenectomy, for example. So if I did block the blood vessels, the blood vessels go into the spleen, for example, I will have splenic infarction. Part the spleen will be dead, as if I did remove it, because it doesn't get any blood delivered due to blockage of its vessels by those clustered sickle cells. All right, is this better, Hanan? Yes. So for Francois, can anemia, yes, affects red blood cells? Yes, anemia is a red blood cell problem. All what we're discussing here so far in the homeostatic imbalances are problems affecting red blood cells. So as you remember, we have three main sets of causes for anemia. So if I have problem with the red blood cell or problem with the hemoglobin inside those red blood cells, or remember how, all right, so those are the three reasons on here. I have insufficient erythrocytes, so I don't have enough red blood cells. I have low hemoglobin, or I have abnormal hemoglobin inside. So the way I think of it here, I have a car, I want to deliver the oxygen. I might not have enough cars, or I have defective cars, low number of red blood cells due to hemorrhage, due to premature destruction. So rather than remaining working for me for 100 days, they will remain only for 50 days. So I have a reduction in the available number of red blood cells. So this will cause low red blood cell count, causing anemia. Or if I couldn't find any drivers to hire, I don't have money to pay for the drivers to come to work for me. Like I don't have iron, for example, or I don't have B12. If I don't have iron, I don't have B12, I can't hire the driver. I'm not able to build up hemoglobin. It's requiring the presence of iron, it's requiring the presence of B12. So if you don't have iron, if you don't have B12, this will cause low hemoglobin content. You don't have enough hemoglobin. What if you do have iron, you do have B12, but the hemoglobin that you're hiring is lazy. It's defective. It has an abnormal shape, like in case of thalassemias, in case of sickle cell anemia. So with this driver, the lazy driver that is not willing to work, will be able to deliver you want. So you see on here, three main sets of reasons. I have either low number of red blood cells, I don't have enough cars, or I'm producing defective cars, or the cars will be breaking down earlier than expected. I don't have the ability to build up hemoglobin. I don't have iron, I don't have B12 to build up the hemoglobin. Or the hemoglobin, although I have the iron, I have the B12, vitamin B12, but I have a genetic problem that causes me to produce defective hemoglobin that won't allow me to carry the oxygen to the tissues due to any, like in sickle cell anemia, this is going to cause sickling of the cells, or in thalassemia, similar concept. Is this better now? All right, so here, Melissa, what causes a lack of intrinsic factor and how is it treated? So defective uh, red gastric cells. So gastric cells, as we're going to learn later on, is a digestive system. We have multiple types of stomach cells present in the gastric mucosa. One of them is going to be responsible for the production of the intrinsic factor. Intrinsic factor here, as it travels down, it enhances the absorption of vitamin B12 from the small intestine. So I'm not worried about the intrinsic factor. I'm worried about the B12. So I won't be trying to substitute the intrinsic factor. I would be trying to substitute the B12. So I can't get tablets of B12. This won't help because simply if you take tablets, you're still going to need the intrinsic factor to absorb this B12 from your small intestine to your blood. So what we're going to do instead of getting B12 or worry about the intrinsic factor, we're going to be given direct B12 into the bloodstream. So how can I have a direct access to the bloodstream here? I will give intramuscular injections of B12, or I will be given using nasal spray for this B12 to be absorbed through my nasal mucosa. The mucosa lining absorbs directly the B12 without the need of the presence of the intrinsic factor. Intrinsic factor is a cofactor that will allow the receptor to take in the vitamin B12 from the intestinal cells to the bloodstream. Does it make sense? All right, so let's move on to our next set of homeostatic imbalances related to the blood. First, we did discuss the homeostatic imbalances related to the red blood cells. Now we're looking at the homeostatic imbalances related to the white blood cells or leukocytes. So if I have abnormally low white blood cell count, this is what we call leukopenia. If I have excessive production of leukocytes and those leukocytes are abnormal, are cancerous. So in case of infection, you're going to have leukocytosis, which is a high white blood cell count, but those white blood cells are fighting the infection. They are working, they have a normal shape, they have a normal uh, uh, metabolism, they have normal action. But here, when we're talking about leukemia, those are cancerous cells. Those cancerous cells are not going to be working efficiently and effectively to reduce the infection. Remember, if we go back to the leukopoiesis, remember we did have two main pathways. We did have the myeloid stem cell pathway, and this myeloid stem cell will be given rise to the eosinophils, basophils, neutrophils, and monocytes. And we did see the lymphoid stem cell pathway, in which that will be proliferating, giving rise to the lymphocytes. All right, so we will classify leukemias according to where did I get those cancer cells from? Are those coming from the myeloid stem cell, or they are coming from the lymphoid stem cell? So if the cell of origin is coming from the myeloid stem cell, we're going to classify the leukemia as myelocytic leukemia. If it's coming from the lymphoid stem cells, it's going to be a lymphocytic leukemia. Acute leukemia involve blast-like cells. And remember, blasts, those are similar to the stem cells. They are much less differentiated. And remember, acute leukemias are going to be much more aggressive, but the good thing here is that, yes, as they are aggressive, they are rapidly proliferating. They don't look like a normal behaving cell, but the good thing here is they will respond better to treatment. They will respond better to chemotherapy. As I am rapidly dividing the cells, I will be reuptaking those medications in, and as I get those medications in, those leukemic cells will be destroyed. So acute leukemias are affecting the blast type cells. They are more aggressive, but they have better response to chemotherapy if they detected early before major destruction, major deterioration of the condition. They will be affecting children, mainly children. Compared to chronic leukemias are going to be leukemic cells. They still abnormal cells, but they look closer to the mature cells. So rather than having a leukemic cell that looks like a stem cell here, a blast cell, this is acute leukemia, they will look like those mature cells. So they have much better behavior. They have much less proliferation ability. So they are less aggressive, but the problem here is that they are also less responsive to medication. I'm not rapidly proliferating. I don't take those chemotherapeutic chemicals in, and thus they will remain living and proliferating for longer time. Yes, they are less aggressive, they are less destructive, but again, it's so hard to get rid of them. All right, chronic leukemias mainly affect the elderly population. All right, so what is the problem having those leukemic cells? They are rapidly proliferating white blood cells, so why should I worry about those rapidly proliferating cells? So a simple concept on here that you can think of, you have one stem cell, and this stem cell is a hemocytoblast. The hemocytoblast gives rise to the red blood cells, gives rise to the white blood cells, and gives rise to the platelets. So having too much white blood cells, how is this going to affect me? First, I start to pull the hemocytoblast towards this side and away from the other two. So this is going to cause a major reduction in the formation of the red blood cells. So can you remind me, what do we call a reduction here in red blood cells? It's an anemia. And remember, what type of anemia would I have? Not producing red blood cells. I have a defect here in my red bone marrow, not being able to construct red blood cells. This is what we've called aplastic anemia. I'm not able to produce red blood cells. Also, I would have thrombocytopenia. I have low platelet count. I'm not producing the megakaryocytes that will be given rise to the platelets. So I have thrombocytopenia, low platelet count, and I have a very high white blood cell count. So what are the three major problems I'm facing in here in this condition? First one, I have anemia. I have low oxygen delivered to my tissues. Another thing, I am more prone to develop hemorrhage. Remember, the first line of defense for you to stop bleeding was to perform a vascular spasm to constrict the injured vessel. What comes after that is the blood clot formation. So before the blood clot formation, I'm sorry, is a formation of the platelet plug. Remember, platelets will cluster, will fill the injured site to reduce the amount of blood loss. So if I don't have enough platelets, what's going to happen? The patient will simply keep bleeding. What is the problem with having too much white blood cells? So if I have an army of 1,000 soldiers and another army with 100 soldiers, which one is more powerful? Having high number of soldiers in my army or low number of soldiers in my army? What do you think? It doesn't matter. If those 100 soldiers are willing to fight and they are trained, those will have much better performance over if I have 1,000 soldiers which are not willing to fight or they didn't get any training. Yeah, none of the above, exactly. All right, so again, having too much white blood cells doesn't essentially mean that you can fight the infection, because those white blood cells that I have too much of are actually defective. They are not going to help me getting rid of the infection. So what are the three major problems on here? Patients will suffer from anemia. Patients will have bleeding. And the type of bleedings that I'm so worried of is going to be the internal hemorrhage. And the having too much white blood cells, but those white blood cells are defective, so those patients will start to develop overwhelming infections. So three major problems here with leukemia would be aplastic anemia, thrombocytopenia will result in internal hemorrhage, and having defective white blood cells produced. Yes, I am producing great number of white blood cells, but those are defective white blood cells. So I will be exposed to the infections to which I'm not able to respond to. So patients, the two major causes of death in here in patients with leukemia would be internal hemorrhage and overwhelming infections. Treatments will include irradiation, anti-leukemic medications, and after I give my chemotherapy, I give my medications, those patients will gonna need a bone marrow transplant. So in a bone marrow transplant, we're gonna be looking for the engraftment. What I mean by the engraftment, that the transplanted bone marrow is producing cells. What we mean by engraftment. If no engraftment did take place within 42 days of the bone marrow transplant, this is going to be considered a failure. If the engrafted bone marrow, if the bone marrow is engrafted, it starts to produce, the transplanted bone marrow started to produce new blood cells. The patient will remain in the hospital for 100 days and then he will be able to go home. Why 100 days? Just to make sure that he is producing enough of those blood cells. So remember, red blood cells will remain for 100 days in your bloodstream. So I need to make sure that all the blood cells that he has now in his circulation are his own production, not from a previous blood transfusion, right? So if he was able to maintain normal red blood cell count for 100 days and without the need of extra blood transfusions, this tells me that yes, this engrafted bone marrow can work efficiently and can substitute this damaged or destroyed bone marrow. Success rate is highly variable. It's going to be greater in sibling donors. The success rate is between 55 to 90%. Unrelated donors, this drops to 25 to 65%. All right, so what is the hormone code that is required to make more platelets? What do you think? I'm waiting for your responses here. Thrombopoietin, exactly. Thrombopoietin. This is a hormone that induces the formation of my megakaryocytes that will be producing the platelets. What is the cell required to make granulocyte? If you remember, granulocyte is a type of what? Granulocyte is a type of white blood cells. Remember, what are the granulocytes? Granulocytes are the white blood cells that do have cytoplasmic granules. Those are either basophilic granules, and we call those cells, those are with the basophils, or cells that did have acidophilic granules, and we call those cells my eosinophils, or cells that did have cytoplasmic granules, which are basophilic, and some others are acidophilic granules. And we call those are the neutrophils. Those are the three types that we've seen for the granulocytes. So remember, granulocytes is a type of leukocytes. It's a type of leukocyte, but it's not, the leukocyte is a broader term, and one of the types of leukocytes is gonna be the granulocytes. So the cell responsible for the production of all blood-formed elements, including leukocytes and everything, is going to be my hemocytoblast. Hemocytoblast is a precursor cell, is a stem cell that is responsible for the production of all blood-formed elements, including leukocytes, including granulocytes. You can't use, it's definitely not erythrocyte, so you don't need red blood cells to produce white blood cells, no. You don't need thrombocytes, you don't need platelets to produce granulocytes. And leukocyte is just a broader term. It's a broader name for all white blood cells, including the granulocytes. So granulocytes are leukocytes. Those are not a more specific term. All right, leukocytes is a broader term. All right, so the cell required for the formation of granulocytes is going to be my hemocytoblast. Moving on to homeostatic imbalances related to the blood clot formation. All right, so if I have an undesirable blood clot formed in an unbroken blood vessel, this is what we call a thrombus. And the thrombus here might be blocking the circulation, and as it blocks the circulation, this is gonna lead to tissue damage. If, for example, here I have a blood vessel, and for any reason a blood clot was formed due to disturbance, let's say in the antithrombin 3. So the problem here causes the formation of a blood clot. Let's say here we're going towards the kidney. So the part that gets supplied by this vessel where I get the blood clot or the thrombus in gonna be blocked, and I will have a wedge-shaped infarction like this. So this part of the kidney is gonna be dead. Same concept if you're dealing with the brain. So anterior cerebral artery, if it got blocked, I will develop a stroke. Part of the brain cell, part of the brain is going to be dead. And it's different from an embolus. Thrombus is different from an embolus. An embolus is a blood clot that is freely traveling through the circulation. So a major example here of emboli is like, and this is something that you're gonna usually alert your patients from after a surgery. You ask a patient to try to walk after surgery to compress the veins of the leg for him to not have a stagnation of the blood in his venous system. So if I've got a blood clot here, I will consider it a thrombus. But if this blood clot travels, it's inside an intact vessel, so it's a thrombus. But if it gets dislodged from its place and now it's traveling freely in my circulation, what's going to happen? If you remember, the venous blood going to be drained back into your right atrium, and then from the right atrium it travels down to the right ventricle to be delivered to the lungs, and this is where I will get a problem. I will have pulmonary embolus causing infarction in part of the lung due to the blockage of the blood vessel supplying this part of the lung. How to prevent a thromboembolic condition? The most widely used medication is going to be aspirin, which acts by inhibiting the prostaglandin that inhibits the thromboxane E2. And this thromboxane E2 is needed for the platelets aggregation. So remember, in order for me to stop bleeding, so if I got an injured blood vessel like this, it's torn, it's injured, I get exposure of the collagen fibers because I've lost the endothelial lining. platelets will cluster and get attached to the collagen fibers, and they will get attached to one another, forming this platelet plug. And remember, those activated platelets are the ones that will be, remember, initiating the intrinsic pathway of the coagulation. Remember, activated platelets activate factor 12, that will activate factor 11, that activates factor 9, that activates factor 8, and 8 and 9 activate factor 10. And remember, activated 10 activates factor 5. Activated 10 is what we call the prothrombin activator that activates the prothrombin into thrombin. Thrombin is going to be responsible, if you remember, to transform the soluble fibrinogen into its insoluble form, which is the fibrin. And remember, the fibrin threads that I will be forming is what I will be using to build up my mesh that seals the injured vessel. All right. So if someone has an embolus, it will only cause a problem once it reaches the lung. No, not essentially. It's according to where the embolus was formed. So in this specific example, like in deep venous thrombosis, if I've got a blood clot in the veins, the first organs that I can get stuck in when I get exposed, when I'm trying to pass it through tiny vessels, and this this uh, this embolus can get stuck, is going to be the lungs. This is the first site where you're going to reach if you're traveling through the venous system. But if, for example, I have been developing, or another example of emboli, like for example, a person who has left atrial fibrillation. So rather than contracting my left atrium to squeeze the blood down to travel to my left ventricle, what happens? The left atrium is fibrillating, is not performing enough force to squeeze the blood down. So the blood can remain for longer within the left atrium, and this will cause the formation of a blood clot. And those tiny blood clots will be traveling down to the ventricle and then will be pumped from the left ventricle to go anywhere, any other systemic organ. So those, one of the major systemic organs that will be affected is going to be, as Tyler said in here, it's going to be the brain. If I did develop those tiny blood clots, it might cause a blockage in one of the brain vessels. So yes, aspirin is a blood thinner. It's going to be reducing the ability of the blood to form a blood clot. So you see on here, aspirin will affect the very initial steps required for you to form the blood clot, which is the aggregation of the platelets to one another and for them to be attached to the exposed collagen fibers. So in order for this to take place, I need thromboxane A2. All right. So here, aspirin here acts as an anti-prostaglandin that inhibits the thromboxane A2, preventing the platelets from aggregating from, if they didn't get attached to the collagen fibers, they didn't get attached to one another, they won't become activated. And if they won't become activated, you won't have activation of the coagulation factors. So I don't have activation of all those factors. And so if I don't have activation of all those factors, I won't be building up the blood clot. All right, that's why your doctor will tell you stop taking any kind of aspirin, before the surgery. He wants to make sure that when he cuts a vessel, it seals. Because if a person went to perform a surgery, the surgeon would be cutting through the tissues, injuring vessels, and those vessels going to be bleeding, and there is he will have a very difficult time aggregating the platelets and initiating the major pathway here responsible for the coagulation. It's the intrinsic pathway on here that we're looking at. All right, so another anticoagulant that we're going to be using, especially with pre and post-operative cardiac care, is going to be heparin. Warfarin is going to be a short acting and is going to be used with patients with atrial fibrillation, as we have seen on here. Patients who have atrial fibrillation, they are going to be forming tiny blood clots, and in order for me to prevent the formation of those blood clots, we're going to be usually using warfarin to reduce this blood clot formation. Any questions? Any questions for me before we move on? Questions? All right, so what do you think about this question here? Glycoproteins on the surface. So how long before surgery? So it's usually recommended at least 10 days or so. At least 10 days. Usually they recommend much longer period. But to be at least 10 days to be on the safe side. Some people will go at a shorter period if it was a surgery that needs to be done as fast as possible. So for the heparin, we didn't mention any specific mode of action for the heparin. So please don't worry about the heparin. Heparin would have different types of molecules, and it has a more complex mode of action compared to the aspirin. So I don't want to get into the details of how the heparin acts. All right, Mary? All right, so moving on to our question on here, glycoproteins on the surface of erythrocytes that we use to determine blood type are called what? Antigens, exactly. So antigens are those glycoproteins present on the surface, and this is how you're going to be able to determine whether this cell belongs to your body or not. All right, so moving on to another set of homeostatic imbalances related to bleeding here. First is going to be thrombocytopenia. This is a a deficient number of circulating platelets. So remember, platelets is the second line of defense, the second line of defense or the second step in the uh, in hemostasis. And remember, in some cases, even I don't have to form a blood clot to stop bleeding from tiny vessels. So all the time, you're gonna have capillaries which are gonna rupture, and those capillaries don't need you to start a coagulation cascade and build a fibrin mesh to seal those vessels. But you're gonna have a you're gonna be mainly relying on the platelets to stop the bleeding from those tiny vessels. If you don't have enough platelets in your circulation, this results in small blood that will be accumulated underneath the skin that doesn't go away when you press it. So let me show you how it's gonna look like on here. So I have tiny vessels rupturing and they don't get sealed by the platelet plugs. So I have this tiny amount of blood moving within my skin. And when I press on those spots here on this rash, it doesn't go away like if a person has allergy, for example. So if a person has allergy or a mosquito bite or something, when you press on it, so it goes away. It goes away simply because you still have the blood vessels intact, so the blood can be squeezed when you press it. But here the blood is stuck within the skin itself. So when you press on it, those petechiae won't go. So this might be due to destruction of the bone marrow, either due to malignancy, like what we've seen with the leukemia, or uh, having a treatment or by radiation therapy. One of the side effects might be more destruction of bone marrow or getting exposed to radiation. If a person got exposed to a lot of radiation, he in his work for any reason, he might have also bone marrow suppression causing a reduction in platelet count. In order for me to diagnose thrombocytopenia, I look at the platelet count below 50,000 per millimeter cube. This number is diagnostic for thrombocytopenia. Treatment here would be by transfusion of concentrated platelets. So patients won't need to get whole blood transfusions. They won't need to have iron overload given them red blood cells. So they don't want to have the red blood cells. They don't need the uh, extra fluid. What they only need is gonna be the platelets. So you're simply gonna be extracting the platelets from the blood and giving them just concentrated platelets. Other bleeding disorders that will cause hemorrhage, those gonna be the hemophilias. And from the name here, hemo, blood, and philia, love. So hemophilias, those are the conditions in which patients gonna love the blood. What I mean by loving the blood, I have greater uh, greater risk of bleeding. I have greater tendency to bleed. And hemophilias are going to be due to defective and deficient coagulation factors. So three common the three most common types of hemophilias are going to be hemophilia type A, B, and C. Hemophilia A is going to be representing 77% of the hemophilia of all hemophilia cases. And this is due to deficiency in factor 8. Remember, factor 8 is a coagulation factor in which pathway? So coagulation in my intrinsic pathway. Remember, intrinsic pathway is started by 12, 11, 9, 8, and then you go to the common pathway starting 10. So here I have defect in factor 8. Hemophilia B, much less common compared to A. It's going to be deficient. It's going to be due to deficiency in factor 9. So you're still here in the intrinsic pathway. So factor 8, hemophilia A. Factor 9, deficiency is going to be hemophilia B. And hemophilia C is going to be also much less common than both A and B. This is going to be due to deficiency in factor 11. So you go here, all the three hemophilias A, B, and C are going to be affecting coagulation factors sharing in the intrinsic coagulation pathway. All right, so you see on here, go factor 8. This is A, B, factor 9, and C is going to be factor 11. All the three here are part of my intrinsic pathway. Symptoms include the prolonged bleeding time and the sides that I am most worried about as a healthcare provider is going to be the joint cavities. So if I have a child who is born with hemophilia, this is a genetic problem. When he becomes 2, 3 years, 4 years of age, he starts to run, and if I didn't have any medical history of this child, first time to see him, he's moving from another country, or he didn't get his mother didn't get a well prenatal care. And prenatal care. So this child is gonna start to run and play and fall on his knee. Most probably, knee is gonna be the most commonly affected joint here. So as I get exposed to trauma, this patient will start to accumulate blood within the joint cavity. So what's going to be the manifestation here of having bleeding in the joint cavity? This child is going to have red, swollen, painful knee. So what is the first thing that comes to my mind when I hear red, pain, and swollen? What I will first think of is going to be inflammation. So you're going to be giving the child anti-inflammatory medications, and you're going to send you're gonna send the child home. All right, so what is the problem here? The problem is that this blood gonna be coagulated, and as it coagulates within the joint cavity, gonna cause the destruction of the hyaline cartilage covering the articular surfaces. And this is going to cause a permanent destruction of this joint for the child. So a very important thing that pediatricians and primary care providers should be aware of when a patient or a child can come in with red, swollen, painful joint and he doesn't have any previous medical records that you have access to, you should check for hemophilia first before you give him anti-inflammatory medications and send him home. All right, because this is gonna cause a permanent problem, a lifelong problem for this child. All right, so our last question here before we move on to break, a brief break for 10 minutes. All right, so what is the blood disorder cause that results in too many erythrocytes? Remember, too much blood cells, more, especially the red blood cells, those are gonna be my, this is gonna be my polycythemia, exactly. So, all right, so this completes our discussion of the blood chapter. We're gonna start our discussion after break with uh, with the immunology. So for Ariel, so what is the treatment for hemophilia? So those kids need to not get exposed to traumas, so they need to be so prudent. They need to have an environment set for them to not get exposed to traumas because they will be bleeding if eh, if they get exposed to traumas. The minor traumas, those even will cause them to bleed. There is a so we can be giving them transfusion of the missing coagulation factor to substitute for to substitute this deficiency. So you're going to be given patients transfusion of factor 8, factor 9, factor 11, according to the type of hemophilia. And those are either going to be extracted from blood donation, for example, or they might be produced in the lab. So, and in order to produce those kinds of proteins, we're going to be inserting the gene coding for those coagulation factors in a bacterial cell, and we're going to be enhancing the bacterial cell to proliferate and to produce this protein for us to extract it and uh, give it to the patients. All right. Does this answer your question here? Yes. No. All right. So we can have a break for 10. We come back, start our discussion of the immunity chapter. So I will be turning off my camera, but I will be back in 10. All right. Good, good, good. Any problem so far? Good.
The adaptive and innate immunity. We're going to be discussing the cells that will get involved in the immune responses, and we're going to understand the difference between the two parts of the adaptive immunity, which are the humoral and the cellular immunity. All right, so first, what is immunity? Immunity is simply the resistance to disease. And the immune system has two intrinsic systems. We have the innate immunity, which is non-specific. It's going to be reducing the infection regardless of the type of infection. It's going to be against any bacteria, any virus. It's something general, non-specific. And we have the adaptive immunity, which is much more specific and targeted immunity. For example, infection like mumps, measles, rubella. The MMR vaccine, for example, gives you a targeted immunity. So your immune system recognizes just measles, just mumps, just rubella, and so on. So it's going to be much more specific. Vaccines for uh, Ebola, for example, or the vaccines that we're trying to get for the coronavirus. We're trying to get a specific immune response targeting one virus or one type of bacteria. So here, those are the two wings of your immune system. We have innate defenses, we have adaptive defenses. Innate defenses, first line of defense in your innate immunity is going to be your skin and mucous membranes. Skin and mucous membranes will act as your surface barrier. So try to imagine I got a wound and I didn't clean this wound. So what's going to happen? I will start to develop an infection. I will start to have bacteria growing inside. I will start to have abscess that will get formed as a result of this infection. So why this normally doesn't happen? Because skin is going to be preventing most of the pathogens from invading my internal tissues. Same for my mucous membranes. My mucous membranes will be releasing the mucus, and the mucus can have antibodies, going to be reducing the ability of the pathogenic particles to stick to the tissue. That's why recommendations for not getting respiratory infection to not get your mucous membranes dry. So keep drinking fluids. Get moisten your mucous membranes for the virus or the bacteria to not be able to attach itself to your tissues and find a suitable environment for it to proliferate. So mucous membranes will act as one of the first lines of defense against infections. Also, try to imagine how many viruses, how many bacteria do we ingest per day? Billions and billions of pathogenic cells that we eat with the food. So why this won't give us an infection? Why this won't cause an infection? Because simply most of the bacteria that we are ingesting gonna be broken down by the effect of the hydrochloric acid released from the gastric mucosa. We have non-specific innate defenses which are internal. Those are either cells or responses, like the phagocytes. And one of the most important types of phagocytes that we discussed was the macrophages. And remember, macrophages were the monocytes that did migrate and live now in the different tissues. We call the ones in the dermis of the skin Langerhans cells. We call the one In the central nervous system, the oligodendrocytes, cover cells in the liver, dust cells in the lungs. So all those are tissue macrophages ready to engulf, digest the pathogens. Natural killer cells, another type of immune cells which act non-specifically. It's going to be targeting any viral infected cell, any cancer cell even. We have non-specific immune responses like inflammation, like fever. Those are responses that are not specific to one pathogen. I can have streptococcal infection and I will have fever. I can have flu and I will develop fever. I can have uh, corona and I will develop fever. So it's not specific. So it doesn't tell me, yeah, this is the pathogen. Something your body will use to defend itself, non-specific. Another part of the innate immunity is going to be the antimicrobial proteins. Adaptive immune responses, those I usually describe the adaptive immune responses as a bird that has two wings. So a bird with two wings on here can fly, but if the bird doesn't have those two wings, I have a defect in one of them, this bird can fly. So the two wings on here for the bird are going to be the humoral immunity and the cellular immunity. Humoral immunity, it's an antibody-mediated immunity. So we are producing immunoglobulins to mediate this kind of immunity. Cellular immunity, I'm using cells that will be attacking the infection, as we're going to describe in details later. So again, we have the first set of immune responses or immune defenses that you're going to be relying on are going to be the innate defenses. Those are non-specific. They are not targeted. Those include external defenses. They will act as surface barriers like your skin, like your mucous membranes. And you do have internal defenses, which are either cells, chemicals, or responses. Cells like the phagocytes, natural killer cells. Responses are like fever and inflammation. Chemicals, as we're going to see, are like interferons, for example. All right, so starting here with the innate defense system, have two lines. The first line of defense is going to be our surface barrier that prevents most of the pathogens from invading the internal tissues. This includes my skin and my mucous membranes. I'm acting here as a mechanical barrier. So rather than allowing one bacterial cell to pass, or rather than allowing 1,000 bacterial cells to pass if I don't have skin to my deep tissues, having skin will limit this number, will reduce this number, making it more possible for my immune system to get rid of the infection. Also, it prevents the entrance of the pathogen, like, for example, breathing dust particles carrying the viral particles, for example, those dust particles and those viral particles rather than reaching down my lungs, causing pneumonia. They will stick to the mucus in my airways. And once they stick to the mucus, you're going to be pushing them out uh, with the effect of the propulsion of the cilia the of the ciliated columnar epithelium in your airways. And that's why, for example, you're going to hear those days uh, that try to not smoke, try to not vape, because this is gonna be drying the mucous membranes. This is gonna be reducing the formation of the mucus in the airways, which will make it easier for the virus to cause the infection. Virus will be able to directly adhere itself to the cells and to proliferate rather than stick to the mucus and you wash it out of your airways. So mucus, like in the airways, acidity, like in the gastric mucosa. Gastric mucosa helps you to kill more than 99% of the ingested pathogens. Lysozymes are enzymes responsible to break down non-specifically maybe proteins, and those are going to be present in the mucus secretions from the mucous membrane. Moving on to the internal immune defenses, start with first the cells, and we have three major types of cells that will help with the innate non-specific immunity. First is going to be my phagocytes. And phagocytes, those are two major types. We have the macrophages and the neutrophils. If you remember, macrophages, again, were circulating in your bloodstream as monocytes, and they decided to migrate and live in your tissues as tissue macrophages. Those are highly important, as we're going to learn later in this chapter, to present the antigens for the other immune cells of the adaptive immunity. Another type of phagocytes, if you remember, those were my neutrophils. And if you remember, neutrophils, those are the cells with hydrolytic enzymes kept inside the cytoplasmic granules. And if you remember, we call them neutrophils because they did have both reddish and bluish cytoplasmic granules. So I have both acidophilic and basophilic granules. That's why we call them neutrophils. Those are the lovers of neutrality. Pedia, pedia love, and neutral. So I have cytoplasmic granules that will accept both the basic dye and the acidic dye. I have both acidophilic and basophilic granules. If you remember, we've given multiple names to the neutrophils. Remember, the neutrophils did have an irregular shape of the nucleus, which was a segmented nucleus, but didn't have any regular pattern of arrangement. So it's going to look different from one cell to another. So that's why we call those neutrophils, those are my polymorph nuclear leukocytes. You remember poly, many, morpho, shapes of the nucleus, and those are my white blood cells. It have different shapes of the nucleus, polymorph nuclear leukocytes. Another type of immune cells that will act again non-specifically, all what we're discussing now are part of, of my innate immunity, non-specific. I'm not attacking any specific bacteria by the macrophages. I'm not attacking any specific viral infected cell. I'm not attacking any specific virus by the macrophages. I'm not attacking any specific bacteria by the neutrophils. I'm acting non-specific. All right. I have general chemicals that will be released from the infected cells or that will be present in case of a bacterial cell infection, and this what will trigger the macrophages and neutrophils to attack them non-specifically. I'm not targeting any specific pathogen here. Same concept for my natural killer cells, and from its name, natural killer cell, what's going to be the main function is to kill. Those are large granular lymphocytes. Unlike the other types of lymphocytes, those ones are non-specific cells that are not targeting any specific pathogen according to what they will decide to attack a cell or not. So if this is a natural killer cell, and those are two of my cells, one that got infected by a virus, so the virus embedded itself inside and it's taken advantage of all the resources present in my cell. And here, this is a normal cell. How the natural killer cell will recognize that it needs to attack this cell and not this cell? It's simply going to be checking ID. If the cell presented just a self-antigen on its outer surface, so this cell is good to go. I won't attack it. But if the cell is presenting viral particles on its outer surface, my natural killer cell will recognize, yeah, I don't have this antigen present on my normal cells. And as I don't have this antigen on my normal cells, this cell has something wrong going on. So I need to attack it and kill it. But actually, the natural killer cell won't kill it. It will enhance it to kill itself. It will induce a cell apoptosis. So I will be inducing the cell to destroy itself, and this is gonna work much better with cancer cells. Do we have cancer cells in the body? Do we get cancer cells in the body? What do you think? Yeah, all the time, all the time. With irritation, cells will turn malignant. But why we don't develop a cancer? If all the time we've got cells that are turning malignant, why wouldn't we have cancers? Simply because we've got those immune cells that will figure out that there is something wrong with the cancer cells or a virally infected cell, so they will start to induce apoptosis and destroy those either viral infected cells or cancer cells. Another major action is that we're gonna see in almost all of the immune responses is that you're gonna be inducing inflammation. And think of it, this is a cell that encountered a pathogenic or a cancerous cell or a viral infected cell. So I figured out I have a problem here and I am getting in a fight. So what is my best thing to do? I try to recruit as many immune cells to come to help me. So how would I be getting more immune cells delivered down here if they are all around in my bloodstream? You simply get more blood delivered to this site. So you're going to get more blood delivered, means more immune cells will reach the site of the infection or the site where you've got a problem with, and those immune cells will help attack any other infected cell, limiting the spread of the infection. Because what happens if I didn't destroy those cells? If those cells which are virally infected are not destroyed, and I did break down all the viral components on the inside, simply what's going to happen, the viral particles will be spreading outside of this infected cell to infect the neighbor cells. And I won't have the ability to limit the infection. If it kept spreading, the number of the viral particles present is going to be enormous and might overcome all my immune responses. All right, so again, what did we mention so far? We're talking about the innate immunity, non-specific immunity. It's not targeting any specific virus or any specific bacteria. This is a broad kind of immunity. First line of defense in my innate immunity is going to be my surface barriers. This includes my skin and the mucous membranes lining upper, lower respiratory tract, my gastrointestinal tract. All those going to be lined with mucous membranes. And remember, mucus going to be releasing, mucous membrane is going to be releasing mucus. In some parts, I'm releasing acids, like in my uh, gastric mucosal lining. In some other sites, I will be releasing lysozymes that will help me to break down the pathogenic particles before they invade the internal tissues. We discussed innate immune cells, two phagocytes. First one is originating from the monocytes, and now those monocytes are living within my tissues. We call those cells now my tissue macrophages. And we've seen a granular cell that has a very high phagocytic activity. And actually, we called those cells bacteria, the bacteria slayers, because they have a very high phagocytic power and they can engulf and destroy the bacterial cells. We've also talked about a non-specific innate immune cell. This is going to be the natural killer cell. Natural killer cell is checking the self antigens on the surface of my cells. And if it figured out that there is something wrong, those cells are not presenting good self antigens, they are presenting pathogenic antigens because uh, or viral antigens, because the virus did take over the metabolic activities of the cell. So now the cell is producing copies of the virus. So some of the antigens the cell going to be presenting on its surface going to be of this virus invading the cell. So once they detect there is a virus, or once they detected this cell is acting in in a strange way, is turning malignant, at this point, the natural killer cell induces apoptosis and starts to destroy those either infected cells or cancerous cells. Again, as we're gonna keep going in the immunity, you're gonna see that all the immune cells, as a response, they will be inducing inflammation. And again, why inflammation? If I have a fight, I need the maximum support. I need to recruit, I need to call in everybody I know. All right. So natural killer cells induces the inflammatory response. So moving on here. So what do you think of this question? An example of the body's first line of defense is going to be macrophages, fever, inflammation, mucus. Mucus, exactly, mucus. Remember, the surface barrier are going to be your first line of defense. First line of defense includes your skin and mucous membranes, and the mucus is one of the one of the most important ways by which the mucous membrane is going to be limiting the invasion of the deeper tissues. We have, as part of the innate immunity, chemicals that again are acting non-specifically. Those are like my interferons and the complement. So interferons are simply the SOS messages that will be sent from the infected cell. So if I have two cells like this, those are two of my whatever cells, let's say epithelial cells of the respiratory tract. And this cell got a coronavirus. It's going to be binding to the surface receptor of the cell. It finds its way on the inside and starts to integrate its genetic material within the cell genome. So what the cell will do, it's going to read the viral genetic material and starts to form copies of the virus. Now the genetic material of the virus is simply integrated within my DNA, so the cell is going to be translating this genetic material into proteins, into lipids that will be forming and integrating together to form those viral particles. So what's going to happen? This cell is going to rupture, and those viral particles going to be released out to reach other non-infected cells for them to do the same thing over and over. The good news that your cells are programmed to turn on specific genes when you get something integrated within your genome. Like this viral genome, when it gets integrated, it turns on specific gene on my normal DNA, and this specific gene is going to be coding for special proteins called interferon. So once the viral gets its genetic material integrated, I will start, so I'm infected, I can't help myself. This cell needs to be destroyed. I can't help this viral infected cell. But what this cell will do, in order for it to save the neighbor cells, It will send out messages, and those messages are what we call the interferons. So interferons will be traveling from the infected cell, and they will bind to surface receptors on the neighbor cells that didn't get infected yet. And once the interferon bind to the surface receptors on here, this is gonna be sending message to the inside of the cell, enhancing the neighbor cell to form antiviral proteins to block the viral particles before they integrate the genetic material within the neighbor cell genome. So here, those interferons are non-specific. They are not going to be produced with one virus and not the others. With any virus, you're going to have interferons produced. So it's part of my innate immunity. It's non-specific. It's an antiviral protein that will be sent from the infected cell. Also, those interferons gonna be mobilizing the cells sitting, waiting for an infection to take place for them to come and engulf the infected cell. If you remember, those are the macrophages. So I'm warning the neighbor cells. In the same time, I'm telling the macrophage, I have something going wrong inside. Please come and eat me. Ingest me, break me down. I don't want to spread this infection. Also, the same concept with the natural killer cells. So this infected cell, once it produces the interferon, natural killer cells are going to be walking around within your blood and other body fluids. And once they see that you are producing interferons, this means that there is something going wrong. So the natural killer cell will come to the infected cell and start to attack and destroy it, along with the internal viral, particles. So interferons are going to be in different types, but they are not specific for one virus and not the others. So some interferons will be helping with some viruses better than others, but they are not specific with this virus. So for example, one way of treatment that they were trying uh, to apply for the corona was inhalation of interferons. Interferons are so helpful in treating hepatitis. But when they try to get interferons inhaled for patients with coronavirus and COVID-19 infection, actually it worsens the condition. Actually, more inflammation was taking place. So the interferons are not going to be helpful with the same degree with all the viruses. And we don't have only one type of interferon, so we have multiple types, and some types are more effective against some viruses and less effective against others. But this doesn't mean they are specific. So they act in a non-specific, broader way. That's why we consider them as part of the innate immunity rather than immunoglobulins. Immunoglobulins are targeting specific antigens on a specific pathogen. All right? All right, so you see on here, we've got the virus entering the cell. This cell gonna be integrate the viral genome gonna be integrated within the cell genome, and as it integrates within the cell genome, this turns on specific genes that will be translated to produce the interferons. And those interferons, once released from the cell, they will bind to this surface receptors on the neighboring cell to enhance them to produce antiviral proteins to block the entrance and the reproduction of the virus. All right, so it's like a prevention for getting the virus. So it's like having an infection. You know, for example, when you drink tea, it makes you feel better, but you already have the infection. So you're gonna tell uh, your mother, for example, that tea helps with the infection. So she is exposed to the virus. She is exposed to the infection, but when she drinks the tea, this reduces the ability of the virus to cause her harm. So Ophelia here, so are the interferons sending the message to the macrophage to eat, to attack the virus? So I can't deal with the virus by itself. So they are released from the infected cell, and they have receptors on different immune cells and neighbor cells. So once the natural killer cell, the macrophage, finds that there is interferon released from this specific site, so this means for them that there is something wrong. So they will come to the site of, or to the source of the interferon, knowing that this is an infected cells. The macrophage will simply uh, ingest. So for example, if this is my infected cells, this is a virus on the inside, and it did release the interferon. This is a tissue macrophage sitting around. So the macrophage, when it detects that there is an interferon, it comes and ingests the whole cell. As it ingests the whole cell, it prevents the viral particles from leaving. And so it gets a chance to not only break down your cells which got infected, but also to break down the virus rather than attacking the cell. So now I have parts of the virus like this. So I'm breaking down the cell that got infected with the virus inside. All right, so I'm not attacking the virus only inside the cell. I'm attacking the cell containing the virus. If the virus is outside of the cell, the macrophage will play no role in limiting this viral activity. It limits the viral activity, pathogenicity by attacking the infected cells, not the virus itself. Because virus is considered dead if it's outside of the host cells. It can't have any metabolic activities without being inside the host cell. All right, so again, what we're talking about today is the innate part of our immunity. We did discuss first surface barriers, skin and mucous membranes. We did discuss three types of cells that share in the innate immunity. Those are my macrophages, neutrophils, macrophages, neutrophils, and natural killer cells. We did discuss we mentioned two chemicals that will play an important role in the innate immunity, non-specific immunity. I'm not targeting any specific virus. Again, I'm acting non-specifically. First ones that we've seen was the interferon. Interferon is going to be so helpful in limiting the spread of the viral infection. So sending warning messages to the neighbor cells, mobilizing the natural killer cell, mobilizing the macrophages to come and destroy the infected cell. What if I'm dealing with a bacteria? So a bacteria is something that has its own metabolism. It can proliferate independently in most of the cases. Some of the bacteria have to be inside the host cell, so they are intracellular bacterial infection. But most of the bacterial cells are going to be independent. They will be able to proliferate outside of the host cell. They have their own metabolism. So this is our bacteria here. It's not inside the cell. It doesn't need to integrate its genetic material. Uh, doesn't need to integrate its genetic material with the host genome, but it causes a problem being proliferating in my body. So as we're gonna discuss in the adaptive immunity, adaptive immune cells gonna be recognizing specific parts of the bacteria. So let's say I've got an immune cell, an adaptive immune cell. It did recognize the eyebrows, for example, of this bacteria. Another one that did recognize the teeth of the bacteria, let's say. So once I recognize the presence of the antigen, I am designed to recognize, I will start to proliferate, forming copies of myself, and those cells will be responsible to produce immunoglobulins, antibodies, that will bind to those non-self antigens I am recognizing. So now I've got immunoglobulins that got released from the innate immune response. So having immunoglobulins attached to the bacteria like this, did it prevent the bacterial proliferation? In most of the cases, it not. Did it limit the spread of the infection? Did it get rid, did it destroy this bacterial cell? No, it didn't do anything of this. But how do I get rid of the infection here? If it's a bacteria, I did recognize it, I'm producing antibodies against this bacteria. Here comes the function of a set of chemicals circulating in your blood called the complement complex. So whenever you have an antigen antibody complex, whenever an antigen produced from your adaptive immune system recognizes an antigen, which has to be a non-self antigen. If it wasn't a non-self antigen, I wouldn't have been able to recognize it and form antibodies against it. All right, so once I have this antigen antibody complex, this will activate a set of chemicals, proteins located normally in your bloodstream, like the coagulation factors that we've seen when we discuss the hemostasis. Those complement are 20 plasma proteins that once you've got an antigen antibody complex, they will start to become activated and they will cluster together, forming channels that will be penetrating the cell membrane of the bacteria like this. Is this helpful in getting rid of the infection? Yes, definitely. This cell doesn't have a barrier, doesn't have an internal environment and an external environment. So anything can pass inside the cell, anything can leave outside of the cell. I have no control on what passes in and out. Not having a barrier due to the presence of those channels filled by the complement proteins will cause the cell to die. So I'm not able to regulate my metabolic activities. Major disturbance of the metabolic activities will be causing the cell destruction. So one of the major functions here of activating the complement complex is to build up those pores integrated within the cell membrane of the bacteria, and this will cause the cell lysis, breakdown of the bacterial cell. Like any other immune response, like any other immune cell, I'm trying to recruit as many immune responses, as many immune cells to come and help me get rid of the infection. So complement, like the interferons, like the natural killer cells, like the macrophages, like any immune response, like any immune cell, I will induce inflammation. Again, why do you need to induce inflammation? You dilate the vessels. Dilated vessels will bring you more immune cells at the site of the infection, attacking and destroying this bacteria. In this case, it's going to be a bacteria. Also, it's going to be enhancing phagocytosis by a process that we call opsonization. It's like putting sugar on a donut, for example. So if you had a plain donut doesn't have anything on it, you're less likely to eat it. But if you put sugar on top of it, you're more likely to eat it. So this is the same concept. So complement here will be marking the bacterial cells, not only marking, it gives a code to the cell which enhances the macrophage to come and engulf and eat this bacteria. All right, so again, three major effects of the complement complex will be enhancing inflammation, promoting phagocytosis by opsonization. It's like putting a sugar coat on top of the bacterial cell for the macrophage to come and engulf. The other thing is going to be forming those pores, those channels within the cell membrane, and those channels within the cell membrane going to allow you to disturb the metabolism of the bacterial cell, causing its cell destruction, its cell lysis. Moving on to another innate immune response, non-specific, is going to be inflammation. Inflammation has four cardinal signs: red, hot, tender or painful, and swollen. So if we're describing an inflamed site, if I told you I have inflammation of my knee, this tells you what? That my knee is red, my knee is hot, I have pain, it's going to be swollen. What causes all this? Again, inflammation in one word is vasodilation. You dilate the vessel, bring in more blood at the inflamed site. And bringing more blood will do what? Will cause redness. So the site where you get more blood to, it's going to be red. You're also going to be getting the heat of the internal tissues delivered to the outside towards the inflamed site. So getting more blood delivered also going to increase the temperature of the site, making the inflamed site hot. It's going to be painful. Remember, connecting the arterioles to the venules that will be draining the blood, we've got capillaries. And remember, when we discuss the vascular system, fluid leaves the capillaries to travel between the cells by the effect of the hydrostatic pressure. What is the hydrostatic pressure? Again, this is a force by which the blood going to be traveling, which is going to be determined by the tissue perfusion, by ability to get blood delivered at certain pressure to the inside of the tissue perfusion. This is what determines the hydrostatic pressure by which you're going to be able to get the fluid out of the capillaries. But how would I get the fluid back from the capillary, from the tissues to my capillaries? So getting the fluid back from the capillaries, this relies mainly on the osmotic force. I am putting the fluid back due to the presence of proteins, due to the presence of solutes in here. Right, so we're gonna be, for Mitchell, we're gonna be taking around 3 hours in our online meetings because we're gonna have some delay until we connect together. So we're gonna be running around 3 hours each meeting. So we're gonna be starting at 10 o'clock. It's gonna run to 1 o'clock. So still have 10 minutes for today, and we're gonna be good. We'll be taking your questions in 10. All right, so back to the inflammation. Back to the inflammation. I've got blood vessels that were dilated. I'm bringing more blood to the site which got inflamed. This will make the inflamed side red, bringing heat with me. It's gonna be hot. And remember, the hydrostatic pressure is a pushing force that will enhance the fluid to leave the capillaries into your tissues. So now I've got a lot of fluid accumulating here between my cells. This causes swelling. And remember, between your cells, you're gonna have nerve fibers. And those nerve fibers, if you are accumulating fluid between the cells, this is gonna cause them to be compressed and irritated. The irritation here of the nerve fibers is what gonna cause the pain. So again, what we're looking at in here, the 4 cardinal signs of inflammation. An inflamed site is gonna be red, hot, tender, and swollen. Again, why is it red? Because simply you're bringing more blood in, higher hydrostatic pressure. It's gonna be hot. You're bringing heat to the inflamed site. It's gonna be, as I increase the hydrostatic pressure, the fluid gonna be leaking out of those capillaries, accumulating between my cells, causing edema, causing swelling of the tissue, and it's gonna be painful simply due to the compression effect of the swelling on my nerve end. So what triggers inflammation? Inflammation is going to be triggered by the injured or infective tissue. So it's even non-specific to the extent where if I get the trauma, the the site that got exposed to trauma will be inflamed. So I'm not only responding to infection in here, I'm responding generally to any kind of injury. What do you think? Is inflammation good or bad? Like what we're used to, it's good and bad. Why is it good? It's good because it prevents the spread of the infection. If I got a virus in here, I'm accumulating the water around it. More fluid gonna be accumulated, preventing the spread of the infection to the blood vessels where it will find its way to disseminate to other parts of the body. So here I am limiting the spread. I'm localizing the infection. Also, it's going to be helping to dispose the debris uh, uh, of the cells and the pathogens. It's going to be washing this injured site. So I've got an infection. It's having an infection. Think of it as if it was a war between your immune cells and your and the pathogen. So you have dead pathogenic cells, dead body cells. So those dead cells are releasing all their internal uh, structures, solutes, proteins, everything. So you need to have fluid to wash out all those cell debris resulting from the infection, all these dead pathogenic cells as well. You don't want to have those accumulating in the tissue, so you're going to be disposing them. Also going to be so helpful in setting the stage for the repair of the tissue to take place. Any healing process needs to start with some degree of inflammation, because I can't heal, I can't rebuild uh, an injured tissue relying on the normal amount of blood that gets delivered to this tissue. If I'm getting normal amounts of blood, this won't be sufficient to enhance the cells to proliferate. It's not going to be effective to bring enough fibroblasts to build up, for example, the connective tissue to heal the injured site. So it sets the stage for repair and healing. The bad side is that inflammation in some parts of the body can limit the functionality of the organ. Like, for example, if for any reason a person develops a nephrotic syndrome, I develop an inflammatory response uh, between the glomerulus and the Bowman's capsule. So this inflamed side end up causing fibrosis, and the fibrosis, rather than repairing and healing the tissue, gonna cause the proteins to leak out in the kidney tubules. All right, so here some types of some size inflammation is going to be disrupted, like having exaggerated inflammatory response with pneumonia. This causes lung fibrosis. Inflammation is going to be mediated by multiple inflammatory mediators like histamine, cytokines, kinins, prostaglandins, leukotrienes, and the complex. All right, so I'll stop at this point. So please, for today, please use the answer sheet that was attached to the announcement yesterday, and please name the different components of the immune system. All right, so again, please type down your answer. Type down your answers. So mention innate, different parts of the innate immune system, different parts of the adaptive immune system. All this, please type them down on the universal answer sheet that was attached to the announcement yesterday. And again, keep a copy of it, a soft copy, with you for you to put all those documents together in one file that you're going to be submitting uh, towards the end of the semester. All right, all of you did get this here. All right, so just say yes, yes, yes. All right, great. So somebody is asking here about when would we have the lab exam. So lab exam is going to be proctored using a website called ProctorU. I have no idea how it's going to be conducted so far. I will be having a meeting tomorrow with a representative from the company for her to tell me how their system works. I'm not sure if there is an affiliation between FSCJ and this company or not, but I've this is the only proctored website that allows online exam, proctored online examination that I've seen on the college website. So it seems for me that this is gonna be the only choice that I have, but I won't make a final decision until I hear back from the dean if we do have any affiliation to any specific company. This is one thing, and I won't be able to tell you exactly how we're going to be proceeding until I meet with the company representative. uh, I have a meeting with her tomorrow, so uh, by late tomorrow or by Thursday I would have hopefully figured out how we're going to be proceeding with the lab portion of the exam. For now, you have the lecture parts of the exams going to be posted like the regular chapter quizzes. So you have the set of multiple choice questions. You can find them under the Canvas modules. Please make sure you have a good stable internet connection to not have it drop when you're taking a test. Uh, for the lab, I will hopefully tell you exactly how the system gonna work for us and how we're gonna be able to uh, register for the test. I will make sure to give you enough time for each test to accommodate the test with your schedules. All right. So, but I won't be able to uh, answer the exact questions concerning uh, how we're going to be conducting this lab portion. I don't know whether ProctorU costs $25 per exam or not. I'm not sure how uh, they do it. I have no idea. So anybody did have a previous experience with them? Would you tell us a couple of days before? Yes. So I will definitely announce on Canvas I will put a list of the exam times and the window for each exam. I will make sure that you're going to have, after the announcement, at least 2 3 days. You should be prepared. You have studied the material over the last almost month now, so this is not a new material for you. So 3 4 days before the exam will be before the exam is available, I will tell you that is going to be available and how you're going to be proceed. Uh, what was the answer sheet is going to be a file attached to the announcement. So answer sheet for the in-class activities, please find the file attached to the announcement on Canvas. So the announcement where it has the uh, invitation for Zoom, the Facebook group, and everything. This long announcement has the file that you're going to use as a universal answer sheet for the in-class activity. Mary, is it possible to change the due dates for the quizzes to the 23rd? So I believe the quizzes uh, are conducted through the same exact way that we are used to. There was no modification to the quizzes or visible body assignments. So we're gonna stick to the same due dates. Right? We will stick to the same due dates for the quizzes, for the visible body assignments. No change in the due dates for the quizzes or assignments. There has been no modification in their dates. Names the different parts of the immune system. So the different components of the immune system is going to be uh, all the different parts of the innate immunity, all the different parts of the adaptive immunity, which is simply uh, a list, on here. The assignment was just given today, isn't due until yes. This question here, this is corresponding to the in-class activities that you're going to be typing on the answer sheet provided, and you're going to form one file with all the activities that are going to be conducted either virtually or we have been conducting in class. So please, in the meantime, scan those activities that you already did complete in class. You have, because all those going to need to be in one large document that you're going to be submitting at the end of the semester. So for example, you put one, skin, so mucous membrane, two, phagocytes, natural killer cells, and so on. Or this is how you're gonna put down the answers: 1, 2, 3, 4, 5, 6, and so on. Does this mean that the class is gonna be online for the rest of the semester? Most likely, yes. So it's not official, but I'm telling you that in what I'm expecting is that it's gonna be conducted online for the rest of the semester. There is no official announcement that we're going to be closing college for the rest of the semester, but from the latest uh, news that I see, that we are following, for example, California, like we are behind California a few days. So today it's uh, I know definitely that they will be closing everything for longer than 2 weeks. So for now, the official announcement, we are closed for 2 weeks. But in my humble opinion, or as I expect, it's most likely won't we won't be back to campus this semester. This is my own belief. So we're gonna start working as if we're gonna be proceeding as uh, completing the rest of the semester as online. And if everything went fine and we return back to campus, we're gonna shift back to our previous schedule. No problem. All right, so there will be no problem. But just here, I'm setting up the course for us to be working in one system for the rest of the semester if things get more complicated. If not, we're gonna be proceeding back. We're gonna return back to our normal schedule, normal class time. Everything gonna be normal. But if there definitely it's so I won't be making any personal uh, policy. I will just follow the official college policy. So I'm not gonna be uh, asking you to attend online or to proceed online if all the other classes are gonna be completed on campus. So I won't do this. It costs 25. It costs $25. All right. So most of the companies, from what I did here, are reducing their prices because of the current lockdown. So uh, uh, I have another professor using lockdown browser and response monitor for exams. Amanda, can you please send me the name or email for this professor for me to check out? So let me write this down. Lockdown browser. So the lockdown browser is part of response monitor. I need to look up this. I'm not sure what is it, but I will look it up and I will compare it to what they will be telling me next tomorrow. Yes, as I watch through your webcam and you need to present your ID to confirm you're the person that will be taking the test. It also prevents you from opening other tabs or it asks you also to rotate the camera 360 to make sure that you don't have any uh, textbook or any files. My FSCJ email is mhanna, mhanna at fscj.edu. Uh, you can always send an email to professor through Canvas app. So what is his name? Or yeah, so yeah, Yvonne, you're responding to Yvonne. All right, I'm sorry. Innate defense surface barrier. Yes. So yes, those are the components of the immune system. Please write them down on the answer sheet that was attached. So there's a question: what kind of system? Immune system. Immune system. For Francois, immune system. Could you let us know how the activities done in classes specifically? We can make sure to submit them. All right, so I need to look back at what we did in class. I need to review the previous course schedule as a previous scheduled activities for me to be able to give you an answer for this question. All right. So, can you please email me? Uh, can you please email me for the previous asking about the previous activities that were done in class? Right. So, or you can simply uh, ask any other classmate about what they have completed. If you didn't miss any of the classes, you should be fine. All right. Uh, so, what do you mean, Hanan? I don't understand. What do you mean by uh, what were the expectations about the lecture exam? Lecture exam is going to be as conducted on campus. It's not going to be proctored the same like the chapter quizzes. Multiple choice questions. You have 64 questions. Each question is going to be out of 1 point. You've got the test is going to be counted out of 60 towards the end of the semester. So you can get up to 64 on the test. So this gives you 4 extra credit points. You said we will be notified once the lab exam will take place. Yes, 2-3 days before the exam is uh, before the exam window starts. I will tell you, hopefully by tomorrow. And just to submit all activities we have done, including the lab pictures and labeling. Yes, exactly. So all the in-class activities, including the lab work. So the blood typing, the heart dissection, the kidney dissection, uh, the quizzes that we've completed in class, all those going to be part of your in-class activities, along with those questions I will be addressing to you through the virtual meeting. Was the live exam portion still includes the essay? Yes, it's going to be the same exact system like what we have been preparing for. You're going to have the diagrams part, you're going to have the essay part, everything is going to be the same. It's going to need to be proctored too for me to ensure that you you are taking the time to study for the lab. Can we submit all the sections as PowerPoint file? Take pictures, put them on. So rather than putting them as a PowerPoint, you can simply add them to a Word document or get a screenshot of them if you are using errors from PowerPoint. If you did design yours on PowerPoint, just you take a screenshot of it and add them in a Word document. And once you add everything throughout the semester in a Word document, at the end, transform it into a PDF file. This is the ones that you're going to be seeing. All right. So I need one file to have everything for it, because we're gonna be submitting this on the very last day of the semester. So I have only 2 days after that for your final grades to be submitted. So uh, to be able to go through that number of documents, I need to have only one document per each one of them. All right, that's why I don't want to have multiple documents to look at. And this was actually what I was doing when you were handing me the hard copy. Again, if we return back on campus, we're gonna return back to our previous system. Nothing gonna be changed. If we and this is what I believe will happen. We're gonna be lock in the campus. uh, should be it shouldn't be problem. So lockdown browser. So my most important thing, I will be looking at lockdown browser. This is one thing. Uh, I, as you're mentioning, it's free. So if it was the same as the other companies, I will definitely go with the free option. But if the amount of security, in my opinion, is not satisfying my proctoring expectation, I won't use it. All right. If it was the same or very similar and it meets my expectation of how is it will the proctoring gonna be processed, I will definitely go with the free option. If not, I won't be able to. All right, so I'm still didn't decide. I didn't meet with the representative. I will keep you updated as soon as I can. All right. Any questions for me? Any questions? All right. Great. It was good see or talking to you today. And take care of yourselves. Follow the regulation. Social distancing is very important. Try to minimize getting exposed to crowded sites. Everything should be fine, hopefully. And we'll definitely see you sometime.